Hello guys, I just wanted to share a case that we just had recently. We had a lady who was brought to the hospital after she sustained a cardiac arrest. She was successfully resuscitated and of course admitted to ICU. The main thing I want to point out that she was very hypoxic. Literally, she had refractory hypoxemia. She was on volume control mode, 100% FiO2 and PEEP of 14. And despite that, she was saturating in 80 to 85%, and she started having high peak pressure. Her chest x-ray showed diffuse bilateral infiltrate, things that you see with flash pulmonary edema, whether cardiogenic or non-cardiogenic, or severe diffuse bilateral pneumonia or diffuse alveolar hemorrhage. We were leaning toward pulmonary edema, cardiogenic pulmonary edema. So with the intensivist help, we were able to switch her to a different strategy, ventilation strategy, and that helped her oxygenation right away. So that bought us some time until we diuresed her and switched her back to one of the traditional ventilation strategies or ventilation strategies. I want you to think for a minute what possibly you could do if you were in that situation. If you have been through the mechanical ventilation course, I think you will have an idea what possibly you could do for somebody who's having refractory hypoxemia with the traditional mode to fix their hypoxia. Remember, hypoxia or hypoxemia has to be corrected as soon as possible. Take priority on everything else. I'll give you a minute and then come back and finish this video. So this is what we did. Simply we switch her to bi-level mode of ventilation right here, which is the airway pressure release ventilation. And as you know, if you have not watched the bi-level ventilation video, please go and watch it. I'll put a link down below this video but it's an inverse ratio ventilation, pressure targeted, time cycle, and intermittent mandatory volume. Let's go over those. So respiratory cycle for this patient, 60 seconds divided by 22, which is the respiratory rate. I have to say, usually with bi-level we tend to make the respiratory rate much slower, but for this case we picked 22 because the way her ABG looking and the retaining of CO2 as well. But again, so this is her respiratory cycle, 2.73 seconds. Inspiratory high is the 2.73. Inspiratory high means the inspiratory time. It's equal to the 2.73 seconds, the whole respiratory cycle, minus the respiratory low or T low. T low means expiratory time. It's only 0.4 seconds. As you see, it's very short here, right here. If you see, the yellow thing is very short compared to the green. So that means the inspiratory time or inspiratory high is equal to 2.73 minus 0.4 equal 2.327. Divide this inspiratory high by, which is inspiratory time, by T high, not inspiratory high, T high, which is the inspiratory time, by T low, which is the expiratory time. This is the ratio, 5.8 to 1, and it's exactly what the ventilator. Okay, so you see there is a huge gap, a huge difference, and that's why that brings me to the next point, that we picked a pressure high of 30. As you see, this is the inspiratory pressure, the same one we use the pressure control, but you don't see anything here. The pressure low or the PEEP is 0, and you can do that, of course, because you spend very short time in expiration, and mostly your time is in inspiration, so mostly you're getting the 30 centimeter H2O. But again, you can use pressure low if you want. So that's the pressure target things. So with each inspiration we give this pressure, and as you see, it's right here, the pressure high. and the pressure low is 0. Time cycle, we just talked about it. So the inspiration will be 2.327, and then expiration 0.4. And number 4, it's intermittent mandatory ventilation, which means the ventilator will give 22 breaths. These are the breaths that fully supported by the ventilator by this pressure. And this inspiratory high, T high, which is inspiratory time, and T low, which is expiratory time. Pressure high and pressure low. Any extra breath on top of 22 will not be supported or partially supported. And here you see, this is the pressure support. We decided to give 0 because simply the patient was sedated and she was not breathing over the vent. But let's say if she was breathing 30, she will receive 22 supported breaths, and the extra 8 will be only supported by the pressure support if you decide to give her something. But here is 0. That means she's not receiving any pressure support during extra breaths, but you can make it 5 or 8, whatever you want. So that's what intermittent mandatory ventilation. And the other thing I want to tell you that the 22 breaths will be delivered at this rate every 2.73 seconds. Regardless, there is no synchrony with the patient. So it's not like a synchronized intermittent mandatory ventilation. The ventilator every 2.73 will give a breath regarding if the patient was in a breath or not. So that's another thing for bi-level. See, it's controlled breaths here because simply she's only getting controlled breaths. So this, after we change her to this, the patient oxygenation improved significantly and quickly, and we were able to switch her to just regular pressure control mode, I think in 5 to 6 hours after we were able to diurese this patient because simply she had pulmonary edema. The last thing is I want to show you the video. This is a video, so let's see.
My eye ratio is like 5.8.
Yeah, look at that.
Okay, as you just seen, she was switched to inverse ratio ventilation strategy, the bi-level, as we just explained. And as you know, this is a strategy you can use in severe refractory hypoxemia. And again, most of the time you will have an intensivist or a pulmonary critical care specialist to help you with those modes, as they come with their own complications, specifically O2 PEEP. And this patient we just explained about, she did have the O2 PEEP, but that's something we were okay with because we were trying to save her life. The good news that she made it through, she improved, and I think right now, as of today, she's undergoing weaning trial because her oxygenation improved significantly after we diuresed her. Her ejection fraction was 35%, and of course she will undergo further cardiac investigations. Hopefully this was an interesting case for you and helpful case for you. Again, if you have not gone through the mechanical ventilation course, or I'll put a link down below this video, please watch it. If you like it, share it. Please subscribe to the channel if you like it, as we will have soon the ICU crash course. It's really coming soon. It will be very helpful for you. See you soon.